Menahan. We're at 8:32. So thanks, Sunny and Don are our two presenters today, and I'll be introducing them. But I want to start with the land acknowledgement. Ottawa is built on unceded Algonquin Anishinaabe territory, and the peoples of the Algonquin Anishinaabe Nation have lived on this territory for millennia, and we honor them in this land. Their culture and presence have nurtured and continue to nurture this land. CHEO also honors all First Nations, Inuit, and Métis peoples and their valuable past, present, and future contributions to this land. Our presenters are Sunny Denani and Don Brinklow. I think most of the people on this call know Sunny. I might introduce Don first. I was reading his bio this morning. Mr. Don Brinklow lives in the Mohawks, Bay of Quinte First Nation, Chenaga, Ontario. His background is in industrial electrical installations, specializing in troubleshooting complex electrical systems. His greatest accomplishment is his family, with his wife Patty, their 8 children, and 12 grandchildren. He strives to honor his heart donor every day, and the thousands of people who have helped him along the way. One of his favorite pastimes is to stand in a light rain. It reminds him of what simple things that can make you appreciate life. Raindrops on his face, the smell in the air, taking a moment to slow down. These are all things that keep him feeling grounded and humble. The rain resets my soul and reminds me of what it feels like to be alive again. Yeah, thanks for that bio. I wanted to read that one first, Sunny. And so Sunny is the chief of the Pediatric Intensive Care Unit at CHEO in Ottawa and a professor of pediatrics at the University of Ottawa. He's the inaugural PICU lead for Ontario Health. He's had a long interest and done a lot of work in organ donation. He's the associate director for donation research for the Canadian Donation and Transplant Research Program. He's now the chair of the Canadian Donation Physician Network, chair of the Canadian Blood Services National Deceased Donation Advisory Committee, and steering committee member for Health Canada's Organ Donation and Transplantation Collaborative. His own area of focus is leading international research pertaining to practices and standards for determining death after cardiac arrest, with special emphasis on donation. So with that, I'll hand it over, I believe, to Sunny first to speak about advances in organ donation.
Okay, thank you. Thank you for everyone joining us today, and especially for Don for sharing this presentation. I'm really thrilled to have known Don for many, many years, and I think people will be inspired, not just about donation and transplant, but really about life. And I think the underlying theme here today is about trust. And in the past, I've talked a lot about research and increasing numbers, and we're going to go through that today a little bit to discuss the numbers. And a particular question that comes up almost every time is, will presumed consent help our system in Canada? And so I wanted to focus on that a little bit, maybe 20 minutes for me, and then 20 plus minutes for Don and some questions. I think that's how we'll play this together. I have some disclosures with a number of organizations and some remuneration from Ontario Health and Trillium Gift of Life. I am the hospital donation physician here, so have a vested interest in OTD, but feel very strongly that this isn't just about transplant recipients, but about our potential donors and end-of-life care here at CHEO and within the province. I usually start with a bit of a story. Here's me with my green shirt. This is a result of Logan Boulay and the Humboldt bus crash a few years ago, where Logan and many of the unfortunate young men that died in that bus crash ended up being donors. And we reflect on that every April 7th. And here's my short. I'm not going to go more into my hockey career because I think Don's hockey career is very interesting when he tells his story. So we'll focus on some metrics to let you know how CHEO is doing, focusing on consent and registration of donation here in Ontario and elsewhere in Canada. And then we've got Don looking very sharp there. Canada does fairly well when it comes to donation. However, it's a rare event. I think people are often surprised when I say there's less than 1,000 or 1,500 donors per year in all of Canada. I think we hit 41 million this year. There are 823 deceased donors in adult and pediatric ICUs. That results in about 3,000 organ transplants a year, leaving 3,000 to 5,000 people on the list in Canada. 1 in 3 of those people, one person on that list dies every 3 days. So those metrics are hard to capture, but we do see a number of deaths on people waiting on the list. Usually it's people on the more dependent organs, lung and heart. Kidney tends to be the most common transplant. Where does Canada fall internationally? So Canada's the red line here. We're about the middle of the pack. Places like the US and Spain tend to be traditionally at the top. And we're going to reflect on those metrics when we look later at consent models and whether our consent model might increase our standing in the world figure here over time. A little bit of background, recognizing this isn't just an ICU audience. When we have organ donation in Canada, it starts with the potential donor. These are individuals who are in an ICU, near death, or already dead from brain dead criteria. The ICU team takes care of them, supported by donation physicians and an organ donation organization here in Ontario that's called Trillium Gift of Life, which is now under Ontario Health. There are coordinators that come to the bedside and manage this on the donation side and on the transplant side. And I think Danny Suttonlong is here, and so welcome to him. And then we have transplant teams, which are separate from the donors and the donor ICU organization, ethically in principle, to make sure that the pathway towards donation as part of end-of-life care isn't influenced by transplant needs. So the process is you're in an ICU, you're gravely ill, you meet criteria to be a potential donor, you fulfill death criteria by either circulatory criteria or brain death criteria. And now we kind of reflect that at the end of the day, it means there's no perfusion to the brain, and that's what death is. Only then can you have organs recovered. This process can take anywhere from 24 to 72 hours with consent from the family. Donation occurs in over 60 hospitals in Ontario, all the pediatric centers included, but the transplants only happen in certain organizations. So those organs are then airlifted or driven, lights and sirens, to other centers. There are about 60 donation hospitals and about 7 or 8 transplant hospitals in Ontario. For pediatrics, Sick Kids is basically the only transplant hospital. So any donor we have, organ donor we have, those organs are then taken to Sick Kids for transplant. We transplant lungs, hearts, small bowels and pancreas, liver, and most commonly kidneys. There's also tissue donation with corneas. In the middle is not bacon, it's bone and skin. And skin often now has moved on to not just skin, but whole tissue. And we've actually had hand and arm transplants done here in Ontario. Phenomenal. We have a process and a system, in fact, legislation here in Ontario, where there's a Trillium Gift of Life Act that says that hospitals are required to report all deaths and deaths that are imminent to establish whether they may be a potential donor. that we have standardized policies and procedures, that Trillium is part of the circle of care and that personal health information is shareable even before the donation process, and that we have a common approach to consent. And again, we're going to focus on consent a little bit. These are our triggers here in Ontario when there's a patient in an ICU, because you can see these triggers: grave prognosis or GCS of 3. They have an injured brain, which is non-recoverable. The families initiated the discussion of donation or the discussion to withdraw life-sustaining therapies, or we've had a discussion with the family to say we're going to de-escalate therapy and withdraw life-sustaining therapies. That's when we're supposed to call Trillium. Sometimes this is 24, 48 hours, even days before anything actually happens with that patient, or it can happen very quickly within hours. What's happening here at CHEO, looking at some of the metrics, over the last 5 years, in fact, we've had 94 notifications. Most of those actually get ruled out prior to approach. There's no fixed criteria of who should be called. We call everyone in and let the organization Trillium decide who we should approach. But these are patients with overwhelming sepsis where the organs are so damaged. Sometimes they're metabolic diseases. Mostly it's oncologic issues that prevent them from being assessed to be a donor. But there's no 100%. For example, there have been patients that have transplanted that have HIV, that have hepatitis C. And again, so that's an evolving landscape. We approached 16 families, and you can notice that actually 9 patients actually didn't survive, so we didn't get to approach them because they were so sick, but we still notified anyways. 4 families did not consent. Out of the 12 that consented, we had 10 donors. 2 patients consented, but we weren't able to move forward with recovery for various reasons. Mostly that's because it takes so long, and we're working on that provincially to speed up the process once somebody consents. A heart has been donated, 10 lungs, 4 kidneys, 7 livers, and 4 pancreas. These are just from CHEO. Not all of them went just to kids, but you can imagine the impact those 10 families had when their young one was passing away and dying here at CHEO. It's for us remarkable. Just last year, it was there were fewer donors, but in fact, I'd reflect in the last 5 years, there were 94 notifications. There were still 21 notifications. For us, that's the first metric we want to rely on. Are we doing our part in identifying potential donors? 2 were approached, 2 consented, and 1 donor, which resulted in 4 lives saved. And so for me, I want to move away from the end result and really make sure that our processes are going right. From pediatric donors last year in all of Ontario, including Sick Kids, Hamilton, London, there were actually 86 lives. Again, most of them pediatrics, but not all. There are still, at any one time, 10 to 30 kids waiting on that waiting list. So there's always a need. There's always a need. Tissue donation is super important as well. We tend to approach more families because they are eligible to be a tissue donor even after death. So even if those families or those individuals come in after a trauma, not resuscitatable, that Trillium then goes and gets consent for tissue because of blood flow, et cetera, that they're more viable to be transplanted. So in fact, we've tried to increase this number, and there were 11 ocular and 2 multi-tissue donations just last year. So really, I would think overall, very proud of the work we do. This is the names on the committee. And in fact, I'd point out Karen and Alex, who are our new family representatives and have made immense contributions to our donation team, as well as multiple other names that you see there. CHEO was fortunate enough to receive 2 awards last year, the eligible approach rate of 100% and the routine notification award almost getting to 100%. Now, what do those metrics mean? There's a picture of Danny there, the tall guy in the back. The rest of us are on the shorter side. Let's go through the standard public reporting scorecard. And I want to really focus on this a little bit because it's one of the things that improves systems. And we'll talk about that when we're focusing on consent rates and whether some of the other things we're doing actually make more of a difference. This was put in place several years back. Routine notification is every person who's imminently dying or has died in our hospital gets called in a timely fashion to Trillium Gift of Life. The conversion rate is of those people, how many actually become donors. You see the metric there last year was 0. That's because there were no potential donors, so they didn't become actual donors. The declaration rate, do we do the determination of death in the appropriate fashions that allows people to be donor? And the eligible approach rate, which is so important to me. Are we giving people the opportunity to say yes to donation? Those are your targets. We want 100% of people referred. And in fact, I would say we want 100% approached if they're eligible. In fact, the target for the province is 90. Last year, last year, our routine notification was 97, so almost 100, and we got the award, and our eligible approach rate was 100, which that's what the award was. This is how we're doing so far, so it's an ongoing metric. We're a couple of quarters behind, but you could see we're maintaining those standards, and that's a lot of hard work from the committee, but all the people at the bedside, the educators, the staff, the OR, and of course our coordinator. That's the metric that I'm really proud of. Can we do better? Often people say, listen, we have a consent model that has me registering on the back of my card. And if more people registered, when the difficult conversation happened near the end of life, would more people consent? Well, there's some thought to that, because when there's a registered decision to consent and Danny goes and talks to the family, consent rates can be as high as 90%. When there isn't a registered consent, that consent rate is almost half. Now, that doesn't apply to pediatrics because we don't register consent for kids, but it's the truth in adults. So the overall consent rate is about 60 to 70%, 67%. When we looked at a couple of years ago at what contributes to higher donation rates, in fact, consent models didn't come to the list. Mandatory referral, which we do, donation physicians, which we have, best practices in brain death and circulatory death donation occurred. And if you look in the middle where Ontario was, we had green across the board, and our donation rates were higher. That's DPMP is donation per million population. If you look at BC and Quebec, the same thing. If you look at other provinces, they were struggling because they hadn't implemented all the things that we had implemented. So consent may not be the fait accompli. In fact, in Ontario, we've continued to grow our number of donors and this is even during a pandemic where we're at the highest numbers provincially we've ever had. That the number of transplants is increasing, and the corollary is the number of people on the transplant list is decreasing from 1,500 a couple of years ago to just under 1,200. There may be some nuance to this metric that we're exploring in that during the pandemic, during COVID, less people are actually put on the transplant list. So I worry that this number will go up again, but in fact, it's something to explore. What's interesting, over the last couple of years in Ontario, despite a ton of money put towards registration and consent, our overall number of people in the province who have registered is about 35%. Cities like North Bay have higher registration rates in the 50%. Ottawa is about 35% consistently. And we have two ways now of registering our donation. Is we can sign our health card or our driver's license, or we can go to the website at beadonor.ca. It takes about 3 minutes to actively say that we want to be a donor. And like I said, when families come to make that decision for their loved one and that active consent is there, the consent rate for donation is about 90%. So I'd launch into you that if you feel strongly about donation, that go to that website and sign it actively takes about 3 minutes with your health card. And then when Danny goes to approach a family, if that was the case, he would have that information to help. In Canada, until recently, and I'm going to talk about Nova Scotia, it's an opt-in consent. And at the time of death, families are still approached, even if it says on your health card, I want to be a donor. There are still approaches say, would you accept that your family member, your loved one's going to be a donor? What's interesting is that 10 to 15% of those individuals actually override the decision of that person who's dying. I think most people are pretty surprised by this. Now, there's pretty logical reasons. Sometimes the interactions with the healthcare team are stretched at the end of life, and the subsequent decision to donation is impacted by that. So the connection with the organ and tissue donation coordinator is very important. The emotional distress and the timing of the process is just too fast for most individuals to rightly so, to be able to navigate. And sometimes it's about the healthcare team. If people aren't dedicated to the process and the culture of donation as part of end of life isn't there, then the override becomes easier. Let me define some terms. In Canada, for most of the country, we have an opt-in process where you have to actively say, I want to be a donor. It's a soft opt-in because of this override option where we still go to families. In some places in the States, it's a hard opt-in. If you signed your registered consent on your driver's license, there is no asking the family. Now, that has come up with some controversy, and I think we can imagine how hard that would be if a family went to the newspaper and said, listen, they're taking my brother's organs, even though I've said no, and it's too traumatic for me. I think that sort of press would be very hard for us. And really, when we look at trust, I'm not sure we're saving lives. Spain and Wales and other countries, and we'll look at that list, have a soft opt-out issue. Legislation where everyone is going to be a donor unless you go into the website and sign that you're not wanting to be a donor. Again, the soft part is that we still go to families and ask them. And in some areas, it's a hard opt-out, which is the most extreme version where all eligible individuals are considered a donor unless that individual explicitly opt out. And if they don't, the family doesn't get a say, and those organs are recovered. That, in general, is pretty rare when we go internationally. This data is a little old, but pretty similar. Where do we lie here? We're somewhere in the middle near the UK. Now, in fact, the UK's color has turned to green. They now have an opt-out model. Interestingly, their donation rates, this is donors per million, has not increased. Spain continues to be on the left side, and they do have an opt-out consent, but when you talk to them, they reflect that it is not the reason for the success. It's all the other things. So Nova Scotia in 2019 has been the first jurisdiction to apply for an opt-out presumed consent model. The first jurisdiction in all of North America. We were all very worried about this because, in fact, if the implementation isn't managed appropriately, there's a trust issue. And in fact, we've seen in some countries like Brazil and France that have very similar healthcare models that, in fact, the trust was deteriorated so immensely that donation rates decreased, and they had to reverse these models fairly quickly. So Nova Scotia wanted to come into this very, very carefully. And this was a project that was funded provincially, where there was a call to action. It was actually the Premier's decision. They didn't even go to the clinician and said, should we do this? The donation lead there was just called into the Premier's office and said, we're doing this in 2 years. They changed the act in 2021, which included deemed consent and some of the other things that we already do, like mandatory referral and the creation of metrics and public reporting. They had 2 years to create system reform, and I'll describe that a little bit. But again, it's some of the things that we already did here, not just a change of consent model, and a huge education and provincial engagement platform. And I'll show you those numbers of what happened when they did this. Unfortunately for them, it was during COVID, and that might have skewed their results. There's a new process now, and we're in the process now of evaluating exactly what happened. So a really great before, during, and after research situation. This is the LEADER program that it was put out, supported by Health Canada, to assess the changes made in Nova Scotia, specifically the opt-out presumed consent legislation. We wanted to, lastly, this is the end process, measure the quantitative impact. We're still doing that, but in fact, understand the experience of deemed consent across the world and how we could learn from that and understand how to do that best and the impact of that within Nova Scotia itself. We've just published this last year. I'd like to highlight these two individuals because they're pediatricians. This was an organ donation system review, but in fact, Matt Weiss is a pediatric intensivist from Quebec City. And some of you recognize, I hope, Christina Krompotnik, who is one of our PICU fellows. So I'm really proud of that. What did they find? Is that actually on the qualitative aspect, the public and healthcare workers actually broadly supported this initiative of deemed consent, presumed consent, opt-out, as it was designed and implemented, which was a soft approach, that once people went through the donation experience, when they interviewed families, that there was support. It wasn't overwhelming. And in fact, there were some underrepresented communities that felt left out now of the decision process. And of course, that was about trust. That in fact, most of the opportunities existed around developing the system, including professional and public education about organ and donation and transplant, rather than deemed consent itself. And so really the underlying theme that only do this if you can maintain trust, the transparency in reporting, and that it aligns with public values. So what we're looking at now is the quantitative aspects. Now you can see the overall numbers are 750,000. It's like the size of Ottawa, to be honest. That once the deemed consent model was put in, there were people who actually went in and opt out, about 13%. That was probably accepted. In fact, the number of referrals since 2020 skyrocketed. So there was something in the system that allowed actually the healthcare professionals to say, listen, I feel better about referring because everyone is supposed to be a donor until they say no. So there may have been an impact here in the number of referrals, or was it the system changes that were put in? The number of approaches, which as I mentioned here, for me at CHEO is the most important metric. Are we talking to families at the right time to give them the opportunity? And is it right for them? And you can see the numbers increasing substantially year by year. Did they actually see more consented donors? Well, actually marginally. You could see this big blip in 2020. That's the year, the big campaign to explain deemed consent to the entire population, which came along with all the other things that talked about end-of-life care, that talked about what happens in an ICU when you're sick, that talked about donation possibilities. That blip happened in 2020, where the actual implementation of deemed consent didn't happen till later on. The number of donors per year actually has increased since 2017. For them, the absolute number is not so much important, but it's about the processes in place. So when they reflected, I think the deemed consent seemed to make a difference in a positive way, but it wasn't about the consent model itself. It was about putting a donation team in place, donation physicians, coordinators at every center, practice leads, family support liaisons, and looking at the quality of the situation, a donor management system and built-in reporting and metrics, again, with family support, to create an education system for the public and the healthcare professionals, really to create onboarding and continued education of staff and the clinical operations, to really put in the network behind the donation organization, which just wasn't there before. And so their reflection is that deemed consent was their avenue to get funding and investment and infrastructure into their province to create those situations. So when we take this and say, should we do this across Canada? In fact, the new guidelines from Canadian Blood Services on death and determination and donation really said, listen, create a consent model that works for you, that registries do help, that make sure there is legislation about consent and there's clarity. And we probably have to address the family override issue, which can still be 10 to 15%. That we need to focus on the healthcare professionals and those conversations with family. So is presumed consent opt-out in the trajectory for Ontario? I don't think so, actually. Our donation numbers are going up. Our number of transplants are going up. And in fact, some of the things we found worked in Nova Scotia, we already have. We have legislation. We have the culture of donation with healthcare professionals. This is our group from the OR. We have donation physicians in place, standardized policy and procedures, and pre-accreditation. We've just done that. We've updated those based on the new guidelines from Canadian Blood Services. We call in almost every death, and we approach almost every eligible family. And then we report those and we compare ourselves to other people. So it's this system that creates success. What does this mean for you who aren't in organ donation? Is one, register. If you feel strongly about donation, have that conversation with your family. But take a step back. And when we're trying to make change in our system and improve things, it's not just about one thing. And it's just not about policy and legislation. It's about building trust. And that's what we need to do. And I think that's the key. It's not about the metrics. We use that as a jumping point to see where our changes go. But in fact, when we've looked at the donation system, it's trust. And that's what happened in Ontario, in Nova Scotia. They created trust. So thanks for listening to me on the focus topic of presumed consent. You can actually, I don't follow X anymore, so you can take @SunnyDanani off. And I'm going to hand it over to Dawn, and we'll have some time for questions. Dawn's in the back. Here are some of my research crew and my patient family partners. And Dawn is a key part of the success of where donation transplant research has come in Ontario. So thanks for your time. And Dawn, I will stop sharing, and it's all about you. Thanks a lot.
Okay, well, thank you so much. And if there's any points that I do miss, Sunny, please let me know. There's a lot of points I want to touch on. So let me begin with this. Normally when I speak, I can speak for hours. So I got a 15-minute, 20-minute window. So I'll give you a Reader's Digest version. So I hope I don't miss too much. Like I said, my name is Don Brinklow. My journey began, or our journey began, just over 9 years ago. We just celebrated our 9th anniversary, heart anniversary. Life has been good, but I want to start by saying that I'm just an average guy. I'm just the average Joe, no different than yourself. When my journey began, it was a normal day like anything else. I was healthy, I was fit, I didn't smoke, I didn't drink. I had a very physical demanding job, so that's what put me in good shape in construction. It was a Sunday, September the 27th, 2014. I'll give you a bit of a background here. I felt off that day. I couldn't put my finger on what it was. I was getting my lawnmower out, getting the snowblower on, getting ready for winter. It was a super hot, warm day, and I had to play hockey that night, the first game of the year. I'm a goalie, and I didn't feel like going, but as a goalie, you can't play hockey without a goalie, right, Sonny? It's a shooter tutor, but it's a little better. So I went reluctantly, and it was the best decision I ever made. I went out to hockey that night. It was the second period. In the whole first period, I felt tired, but you can't figure out what it was. Just into the second period of the game, a guy came across the blue line. He took a slap shot, and before the puck got to me, I felt a little flick inside my chest and blacked out. That's the last thing I remembered. They said that the guy took the shot. I reached out. I stretched way out. I made a save. They said it was like a TSN moment. They were wishing somebody videoed it, but I went down, and they thought that I hurt my knee. So they did a line change. When the line change came out, the first guy out came out. His name was Curtis Clark, who was a first responder with the Belleville City of Belleville Fire Department, and we were playing another fire department. So everything was perfect. He came out onto the ice and he says, I got to you. I heard your death breath. He said, I rolled you over and you were gone. He immediately started CPR. The rest of the team, they all came around. They got me stripped down on the ice, bareback, which is another story. It kind of lowered my core temperature. The arena manager seen what was going on, and there was a defibrillator in the arena, which made a difference. So within 3 minutes, they had a defibrillator on me. I was gone for 17 minutes before they got me back. I do not remember any of this. I got on to, they got me on the ambulance. They actually, with the Desert Island Fire Department, the reason I played goalie is I have an identical twin brother who was out of town, and we both played for the same team. He was away, but unbeknownst to me, he came back and didn't tell anybody because he just wanted to have a down day. When the call went out to the arena, he said, I knew it was you. He said, something told me. Man, it gets hard. So anyways, he came in. He said, when I came to the arena, I just prayed that it wasn't at the back door of the entrance, because that's the end we always played in. And sure enough, when he came in, there I was. So he was one of the first responders that had to work on me. So you can imagine it was hard. His son is also in the fire department. They came in, they took charge. They told Daryl, there's another gentleman on the same team who had a heart attack with us the same night, 2 of us. So they took Daryl to look after Bruce and Nick, and the rest of the team stayed to work on me. They got me up, they got me to Napanee, and then they shipped me to Kingston. They called the family. When I got to Kingston, Dr. McClellan and her team, amazing people. They got me in. I had 2 more cardiac arrests before they were able to get the stent in place to save my life. So that night they called the family. Well, the family was mostly there at this time, but they told the family they gave me 24 hours to survive. The only problem with that is they told everybody but me. So I went on for 24, went on for 48, 72 hours. I was slowly responding, but then I developed a respiratory infection while I was being intubated. In the cath lab, I'd vomited and nobody had seen it inside my lungs. So I was taken from ICU and put down on life support. I woke up a month later and it was just one big sleep. So when I have another story where the month that I was gone, I'll save this for another time. It's like a story, what I experienced, where I went, who I saw. And so now that it's a month, I wake up, I start walking, they send me home. My health continued to deteriorate. So I went back to Kingston a few weeks later for a checkup. Dr. McClellan was able to send me through to Ottawa. So I got to Ottawa thinking I was going down for medication adjustments, and what it turned out to be was a workup for a transplant. So now this is like the middle of November. They come to me December the 17th, 2014, and said that my health had improved enough that I was able to put on the transplant list. Luckily for me, I am an A positive blood type, which is the ultimate acceptor. So I got on the list. 3 weeks later, they found my donor. He was a 20-year-old male who was from Whitby area. He passed away from brain death. He suffered from MSUD. I don't know if you guys might be familiar with this. It's a maple syrup urine disease. He had a very young age. Through pediatrics, they kept him alive until he got outside pediatrics and in the general flow of the hospital. So when he had an episode, they weren't familiar with it and they weren't able to catch it. And what it is it causes your brain pressure to increase so much. His average day brain pressure would kill the average person, but this is what he knew and this is what he lived with. So he succumbed to it. And because he was a donor, he told his family that he wanted to be a donor. He wanted to make a difference. So when he did pass, his sister is what told his parents that, you know what, remember, he wanted to be a donor. So they approached the donation family, and the rest is history. December the 7th, I had my heart transplant. So that was a Wednesday night. The transplant went well. And I'm going to get off on another subject here. One of the last conversations I had before I had to go down for surgery that night, I was walking down the hall with my son. We had one grandchild. Her name is Isabella. So there's Tyler and myself and Isabella. We're walking down the hall. And I said to Tyler, I said, if the outcome isn't what we hope for, I want you to please don't let Isabella forget me. Well, since then, we've gone from 1 to 12 grandchildren. Actually, number 12 is due in about 2 weeks. So you talk about life medicines. I could never understand why people said growing up, I wish I had my grandchildren first, because I always thought that was so weird. But now that I'm here, I totally get it. It's amazing. I love my grandchildren. I love my kids, but they're invited by appointment only. Grandkids can come anytime. So I had my transplant. Within 24 hours, I was waking up. Within 3 days, I was starting to walk. In 5 days, they moved me from ICU down to a step-down unit. Day 9, I asked to leave the hospital. I remember Dr. Chi saying, "Are you nuts?" We'll see. There was a Friday, so I asked, "Okay, can I get a day pass?" I wanted to leave the hospital. I wanted to know that if the hospital said I could leave, then that means I made it. So Dr. Chi said, "Not a chance, but we'll see what happens on Monday." So when she left, my wife Patty was there, and she said, "Why do you want to leave so bad? Where do you want to go?" And I said, don't laugh at me, but I said, I want to go to a pub. I want to have some beer and I want to have some wings. I want to celebrate being life. And my wife Patty looked at me like I was a cyclops, saying, "Where did this come from?" I don't drink. When we go for dinner, Patty would order wings. I would order steak and be cheaper than the wings. So we didn't get the day pass. Monday came, 12 days post-transplant, and I got the boot. It is amazing. So it means I made it. So I'm going to speed up a little further here. 6 months post-transplant, I got a letter from my donor family saying, "Dear recipient." And they start talking about their son. And that's when I found out what he passed away from. And since then, we've met our donor family. We've had dinners together. The donor family and myself has spoken at Trillium event, even though they had a disclaimer because they don't want people to meet, ideally, because it can go good, it can go bad. So they talked about their son. I'm going back again. They talked about their son and his sense of humor, his ability, his singing abilities, and which is like, I think I sound good. I'm singing, but I don't. So they talked about his favorite pastime was to go to a pub, have a beer, but he always wanted to have some wings and stuff. But because of this MSUD he had, he couldn't have proteins, which was increase his cranial pressure. So when we were reading the letters, like, this is where it came from. Why I all of a sudden wanted to have some beer and wings. And to top it all off, after the first meeting we had with my donor family, we stopped at a pub on the way back to celebrate having the speaking engagement and to celebrate their son Matthew. So I ordered some wings and ordered a beer, and they said, what beer would you like? And I said, I'll have a Ricker's Red. Well, my daughter's dad, Pete, his jaw hit the table. He said, that was Maddie's favorite beer. Oh, that's what I was craving. It's like, coincidence? I think not. I think Maddie is with me. I know he is. Once a month we go out for beer and wings. We raise a glass in his honor. I think about him every day. I love life. You can't say enough. We've done several speaking engagements. Actually, I try to do as many speaking engagements as I can. I never miss an opportunity. If every day I could plant one seed to get people thinking about donation, I agree with Sunny as well. It should be an opt-out process, even a soft one. But even the soft opt out, and I agree, it's about timing. I think a lot of time it's quick. Emotions take over their decision making, and they think I can't do this right now. I've had friends who've been donors that have been overridden because of the family at the time was too emotional to make the decision on part of their loved ones. I lost a friend last year who was going through the process of needing a heart transplant, who succumbed before he got his heart. One of my best friends. So it's around us. A lot of people don't see this donation process until you're in it. And once you get involved, how your next door neighbor can have it, and you don't even know it. So as far as when it came to my situation, I want everybody to realize that the ripple effect that it has, what the Donation Society has done for me and my donor, the ripple effect has been huge. No matter where I go and when I talk, people always come to me, just so you know, I signed my card. Because of you and your stories, I've signed my card. And I want people to know this. So, I mean, even though I'm only one, I'll give another, this is a hockey scenario or a hockey, how I look at myself. In 2012, Sidney Crosby Canadian Tire did a commercial about Sidney Crosby. I don't know if you guys remember it. It's worth looking up, and then put donation in place of hockey. He's taking a face-off against this little boy. And as it goes on, they start seeing coaches, volunteers, arena people that run the management, the village. Everybody comes jumping over the boards, and they stand behind this little boy. Now, I'd like you to look at it the other way. This is what I want people to see when they look at me. They see me. They see my donor family beside me. They see my family beside me. They see the responders, everybody that got me to this point, and the thousands of people that are still involved in my life today. I am one person, but I represent so many responders. Sunny, people like the pediatrics, all the doctors, the nurses, the janitors, my pharmacists, their teams, the paramedics, the phlebotomists. I'm here because of so many people, and I represent thousands. So that's what I like people to, when they look at me, that's what they see, is not just me. And my heart also goes out to harvest teams. I think you guys play a huge role. And the people the doctors that can make that call to make it happen, it's a big decision. It's emotions over realistic goals. The harvest teams, what you have to deal with how do you go home at night? You guys are all heroes. I can't imagine how you guys do it, but I am forever grateful. Everybody else is, my family is, my community is huge. Here on Tayanaga, First Nations, I am not Indigenous myself, but I've lived in the community my whole life. So I feel like I am part of the community, and the community feels like I'm part of them. So I'll wrap this up. I would like to, if I get the opportunity, and anybody has any questions, to talk in person. There's so many more details I'd like to go over, but I want to say thank you for the opportunity. I want to say thank you for saving my life, and remember to love life. And it doesn't get any better than this. Thank you again. Thanks, honey.
Don, that was amazing. I'm sure there are less than dry eyes behind those screenshots. But and so thank you. Thank you for bringing the reality to this, not just the numbers, right? These are people and stories, and maybe just reemphasizing that this is about celebrating lives like yours, and
Yes.
celebrating teams like ours. Like I'd really like to end by saying CHEO has done so well, from the Emerge team to the educators to the committee and Trillium as well. And we should be proud of the work we do for stories like this. And I'm really thankful for that. And if everyone can, at least for today, celebrate a bit of life, because that's what's important here. And we're open to questions. As I said, Dawn is open to chatting after. If they're personal things, I can link you up, or we can answer some questions now. Sometimes it's hard after a talk like that to ask questions. I get it. Dawn, you're getting a ton of comments of thank you from a lot of smart and very caring people. So that's nice. Danny, thanks for the update. In fact, last year, it wasn't one heart. Sorry, over the last 5 years, it's not one heart donated, it's 10 hearts donated. So that makes Dawn's story even more relevant for the work we do here at CHEO.
Oh, thanks, Sunny and Dawn. I think that's both very informative and very inspiring. Uh, I'll open up the floor to questions, questions or comments. So we're getting a lot in the chat, and again, Dawn, a lot of thanks to you for your story, sharing your experience. um, does anyone have a question or a comment they want to verbalize?
Maybe I'll just add one thing. Dawn's story really, really a big part of it is connecting with the donor family and that donor story. In fact, that's not a routine practice in Ontario. It's not prevented, but it's not a routine practice because of the potential for more conflict to arise, either for the transplant recipient or for the donor. Don's a great guy, so any donor family, I think, would really be thankful for someone, but that's not always the case. People don't gel and mix, and sometimes the stories of the donors are very traumatic for a transplant recipient. In Nova Scotia, they added that into the legislation, that is okay for them to share, and they're creating a model. I think over time that'll be the case in more jurisdictions. Because it's just so easy to do now with social media and people able to connect themselves, that we probably have to create a better system to support people like Don and his donor family to be able to connect and grow together, because it's going to happen anyways. So that's another area where we're looking at research to try to see how to do that better.
Yeah, mine was found through social media. 12 people removed put the pieces together and contacted the family, and the family reached out to me. And it's been, yeah, you're right. It's been I've been blessed all around, and I've been so fortunate. Like, the family has been amazing, my donor family.
You have a question or a comment from Kara?
Hi, Dawn. Kara here. I'm one of the folks training in pediatric ICU with Sunny, and I just really wanted to thank you for sharing your story. Sometimes it can be really hard to, have patients that we're not able to save and then make that transition to kind of end of life, and contacting Trillium and discussing donation. I always found that really painful, but it's so inspirational to hear your story and see you and see how much good comes out on the other side of that difficult conversation. And I really appreciate you sharing that today. Thank you so much.
Oh, thank you so much. It's amazing. Like I said, it's been good or bad, no matter what. I would think having a conversation, if it's a good outcome or a bad, you're still moving forward. You're still planting seeds, giving hope. My donor family, that's one thing they're so grateful for, is that they know that as much as it was a hard conversation and hard decision for them, that their son lives on. And they're quite happy that they made that decision. It gives them a peace of mind.
Yeah, Don, when you were telling your story, I kind of halfway through when you were introducing Maddie as your donor, I got distracted. Then, my clinical background is in inherited metabolic diseases like maple syrup urine disease.
Okay, yes.
And so, the idea of a patient with maple syrup urine disease where, usually I think of that disease in the context of a transplant recipient, for a liver transplant. And it reminded me of a patient I'd known for a long, long time, as a child who became an adult, tried to follow him as an adult when he moved to the Ottawa area. And, had that same experience where the adult healthcare system was not familiar with the care of a patient with maple syrup urine disease. And after a couple of close calls, really in that adult system where, it could have gone either way. He could have died, trying to, during one of his decompensations, had a couple long chats with him and his mom, and I sent him first to UHN, which turned him down, and then over to London, so London Health Sciences Centre, where they did do a liver transplant. And, honestly, I do think of it as saving his life, because the adult system knows how to take care of a patient with liver transplant. And they really honestly don't know how to take care of a patient with maple syrup urine disease. And he sent me a picture. It's probably one of the last times I talked to him. And that's a great thing, honestly, is me not needing to talk to him. But he sent me a picture of him eating a steak hoagie. So, something that he would never have experienced, and this massive smile on his face, this 40-year-old guy at the time, and really did both save his life and change his life. So while you were talking, when I'm still not settled in this office, but I have this picture of him with that hoagie. I was hoping to find it for the question and answer period, but I couldn't. But, just that symmetry of, donation and recipient, and, all the varied areas in which transplantation can be life-changing. So, I thought I'd share that given your story, on the other direction. Yeah.
You're the first one I've ever spoke to that knew what I was talking about with MSAD. Yeah, it was like, oh my goodness, this is so cool. Yeah, and to add, like you said, and you saved a life. Like, especially in pediatrics, can you imagine being able to give a child to a burn victim some skin or sight or hearing? Like, you really do save their lives. You change their lives. So donation is it's boundless. Like you say, it's amazing. But no, thank you for sharing that. That would have been a cool picture to see.
Yeah, I'll find it. It's in a box somewhere. Yeah.
Thanks everyone for your time today.
Yeah, so we're up at time. So thanks both to Sunny and Don. I think both for helping us understand more, but also making sure that this team remains very high on everyone's radar, and highlighting the good work being done here and elsewhere in making this happen. So thank you again.
You.